when it comes to acromegaly, we usually say you should know the ICPAM of acromegaly. All of you should be used to the ICPAM system by now. So the I is the introduction, the C are the causes, the P there is the presentation, the A is the assessment, and the M is the management. So it's simply a summary of everything that can come out in the exam. So when we talk about the ICPAM system, we're simply telling you, can you tell us everything that can come out in your exam or everything you can see in the GP practices? So in terms of introducing acromegaly, is simply excess growth hormone. That's just it. And this will lead to other problems. So bone problems, joint and soft tissue problems, body organs become overgrown and all that. But the main problem there is excess growth hormone. And what are the causes? 95% of the causes pituitary adenoma. So we've just got tumors and ectopic growth hormone releasing hormone responsible for about 5%, the remaining 5%. So pituitary adenoma or pituitary adenoma is what you need to know for your exams. Now, how does it come? These patients will typically come, if it's an older patient or a 10-year-old, they may come with joint pain and muscle aches, arthralgia and arthritis. Well, a lot of them will talk about blood pressure increase. So this will be an older patient who has the physique of a patient with acromegaly or gigantism, and you check their blood pressure and you notice it's on the roof, 200/110, then you're probably dealing with excess growth hormone. Well, some of them will have problems with their wrist carpal tunnel syndrome. So anybody that has the picture or the pattern of a patient with acromegaly presenting with wrist pain or pain in their hands, please think carpal tunnel syndrome. Well, diabetes is very common in patients with acromegaly. So if you see high HbA1c in a patient with that same kind of picture, please do think you may be dealing with acromegaly. Enlarged organs is another thing. So if you do a scan, you may see very big liver, bigger than what it should be, enlarged heart without having cardiomegaly and all that. Field defects. So the commonest eye defects they have is bitemporal hemianopia. That's an exam question. So please, if you see bitemporal hemianopia, one of the things you should think about is acromegaly. It's actually indirectly related to pituitary adenomas. Yes, goiter. So you see a big swelling on the neck. Please think acromegaly can be a cause. Some of the patients may complain about galacturia, so milk from the breast, very common due to raised prolactin. And then sweating. Excessive sweating is hyperhidrosis. So hyperhidrosis is another thing that they can complain about. And of course, one of the commonest presenting features you see in your question is headaches and increased shoe size. So the patient will say, my shoes are no longer fitting, doctor. Please start to think that is acromegaly. Or I've got my ring, my wedding ring, it cannot fit into my fingers any longer. That is acromegaly. So remember that this is easy learn, and a way to make you learn it easily is to remember it with the alphabet A to I. A for arthritis and arthralgia, B for blood pressure, C for carpal tunnel syndrome, D for diabetes and dental changes, E for enlarged organs, F for field changes or field defects, G for goiter and galacturia, and your H is hyperhidrosis and headaches. I is increased shoe size and increased hand size. So one of these will be in your question, probably be a 45-year-old male, known to have a very big body, now presenting with change. His new shoes that was bought for Marks and Spencer's can no longer size him, and he's quite worried. That is acromegaly. You check his blood pressure is increased and he's complaining about wrist pain. He's also diabetic. This is all acromegaly. So assessment in the GP practice, if you really want to do anything, insulin-like growth factor should be done. However, insulin-like growth factor 1 is better done in hospital. Some areas do allow you to do it, and that will be non-specific. Sometimes it has So it's got a degree of false positive results. So it's not a very good test, but it's usually the first line. And then something more definitive will be to do an OGTT, so oral glucose tolerance test. And that sometimes helps you to confirm your diagnosis. But clinically, you can pick up acromegaly without doing any tests. And if you are trying to spot pituitary adenomas, you need an MRI scan. So those will be typically what you'll be looking out for in the exam. I would say OGTT should be your first go-to in the exam, because not all acromegaly are caused by pituitary adenoma, which does mean that if you are waiting for an MRI scan to diagnose acromegaly, then you may not make the correct diagnosis. If it's caused by an ectopic growth hormone releasing hormone, for example, or if it's caused by tumors elsewhere in the body, the MRI of the head will not show that. So it's always good to combine these things together, your OGTT and your MRI scan, in an ideal world, to make your diagnosis. Now, management, usually if one person has had it, it's always good to do a genetic counseling, because there's a chance that someone down that lineage can have it again. So genetic counseling is mainly for the patients themselves as well, just to make sure that they are aware of this and they can also let others know that they've got this diagnosis. Medical management, so somatostatin analogs, example, popular medication octreotide will be what you go to. And remember that sometimes that doesn't work. So where do we fall back on? We fall back on dopamine agonists. So either the AGOT or non-AGOT derivatives. Now, one of you saying, I've heard about this medication before. Well, dopamine agonists are used in the treatment of patients with Parkinson's disease. Dopamine agonists are also used in the treatment of patients with restless leg syndrome. So think about your AGOT derivative and your non-AGOT. So AGOTs will be things that are, we remember it with B and C, bromocriptine and carbagoline. And non-AGOTs will be your ropinro, your pramipexole, and your rotigotine. There are about 4 or 5 of them. So if you remember those medications, they are all dopamine agonists. They are also used in the treatment of acromegaly. Well, now there's a new hope for patients who are not responding to medical management. Pegvisomant is a medication that helps. Pegvisomant is a HGHA or HGH analog, so human growth hormone analog. Quite a very good good invention. It's still rarely being used. Some places now use it. Many places are still not using it, but it does help as an add-on treatment for patients with acromegaly. Now, if you've tried medical management, you've tried human growth hormone analogs, they are not working, what do? If the patient does have a pituitary adenoma and patient is having distressing symptoms, this is where to do surgery. Transsphenoidal surgery will be definitive for a patient who's got pituitary adenoma and is presenting with symptoms of acromegaly. Well, radiotherapy is an option, but radiotherapy has poor results. The outcome from radiotherapy is not very good. Sometimes the patient does go into a lot of complications, and radiotherapy doesn't always work. So sometimes the patient will have what we call a new onset symptoms of acromegaly after radiotherapy. But where is radiotherapy useful? If you've tried everything is not working, then radiotherapy is used in the management of refractory acromegaly. And he's got constitutional symptoms of cancer. So someone may mix that up with symptoms of diabetes, which you're not totally wrong, because fatigue can present with diabetes. Weight loss can come with diabetes, but can this come with cancer as well? This can be symptoms of cancer as well. Bone pain, tiredness, and all the loss of appetite, they can come with cancer. So this patient has got cancer. He needs a CT abdomen. Let's stay with you. I present to you Bubu. Bubu is a 35-year-old female who was admitted to the medical ward on account of lethargy, fatigue, anorexia, nausea, vomiting, and weight loss. On examination, Bobo is hypotensive and hypoglycemic. Her past medical history showed only vitiligo. What is the likely diagnosis? What do you think? What are you thinking with this picture?
Addison's disease.
Addison's, correct. So why did you pick Addison's? Why is it not something else? What were your clinchers?
Because this patient has got like fatigue, weight loss, anorexic symptoms. It's mainly the hypertension and hypoglycemia, and this got a history of vitiligo, which is an autoimmune condition.
Lovely. Again, another thing is that vitiligo may have been misread. So Addison's does present with pigmentation. It could be hypo or hyperpigmentation. So that could have been an Addison's pigmentation, hypopigmentation, that was read as vitiligo as well. So if I stay with you, what is the commonest cause of Addison's disease in the United Kingdom?
Is it something to do with adrenal gland? Is it something benign tumor?
So it's autoimmune. Autoimmune. In your AKT, you see that question, just smile and rub your hands together, pick the answer. Is autoimmune. So usually in the United Kingdom, commonest cause of Addison's is autoimmune. How about if I asked you about Africa? What would be the commonest cause of Addison's in patients in Africa? What do you think?
Sorry, I don't know.
Yes, so it's tuberculosis. These are common questions in the AKT. For UK, it's autoimmune. For Asia, Africa, rest of the world is tuberculosis. Great attempt. Thanks. So Addison's disease, what's happening in Addison's is primary adrenal insufficiency. There is a problem with the adrenal gland.